all been waiting for the answer to this case study I put before you about this 32-year-old male who presented to the emergency department with severe chest pain and shortness of breath. So maybe some of you are looking at this and like, what is all these, squiggles going up and down, and what the heck is this thing? So I thought it'd be good if we took a little bit look at what a 12-lead EKG is. And we'll look here. You'll notice there's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, and 12. So the reason why we call it a 12 lead is because we actually have 12 leads, or not 12 leads, but 12 angles that we look at the heart. And this is important because we want to look at all sides of the heart. So for a 12-lead EKG, we actually only put 10 leads on a person. So it sounds kind of confusing, but we only put 10 leads on, but we get 12 different views of the heart. So we have the right arm, we have the left arm, we put these patches with the wire on it, and then we have the right leg, and then the left lower leg. Then we put what's called, so these are called the limb leads. Reason why? They're on the limbs. Makes absolutely sense. And then we have what's called the chest leads. And they're called the chest leads because they're put on the chest. Sometimes these are also called the precordial leads as well. So we have V1, V2, V3, V4, V5, V6. And the heart is situated kind of in this circle where I'm looking at, that general vicinity. And so we put all these different leads on so we can get a good view of the heart, basically a 360 view of what's going on electrically. So, what are those squiggles about? Well, I thought this would be a good opportunity to show you. So this thing right here, this little bump, you can see back over here, we have a nice little bump here, nice little bump there in front of this huge spike, and that's pretty consistent. This one you have over here, but it's just inverted. It's not always uncommon in those leads. What are these? Like, what do these indicate? So with an EKG, we're measuring electrical activity of the heart. Remember, the heart works off of a little bit of electricity, specifically these ions called potassium, sodium, and calcium, and magnesium. They use all of those as these positively charged ions as electrical forms of electrical current. So in the heart, we have what's called the right atrium. We have four chambers of our heart. We have the right atrium, the left atrium, the right ventricle, and the left ventricle. So we have a 4-chambered heart. That's how our bodies work. Some animals have 3, some have 2. We specifically have 4. It's pretty cool. What happens is all the blood comes down this blue tube here. We call this the superior vena cava, the one I'm moving my mouse on. And then underneath, it's called the inferior vena cava. So all your blood is going to come to the heart from these 2 vessels. All vessels drain into these 2 vessels, your superior and inferior vena cava. And they drain into what's called the right atrium. Now you can't see this because this heart is not dissected, but the right atrium then pushes blood into a chamber that's located about here. That is called the right ventricle. So the right ventricle then pushes blood out here through what's called the pulmonary artery. The pulmonary artery then goes to the lungs. And why do we want blood to go to the lungs? Well, we need the blood to be oxygenated. So it's blue because blue blood is not oxygenated, at least in this example. So that goes to the lungs, and then they drain through what it's called these pulmonary veins. You got 2 on this side and 2 on that side, so a total of 4. And they drain in what's called the left atrium. And you're like, you're pointing on the right side. Well, we go off of the patient's position. So this is the patient's left atrium. That goes into the left ventricle. Now the left ventricle is probably the most important ventricle because this big puppy here pumps all the blood out to the rest of your body. So this whole left side is responsible for pumping blood to the rest of your body. And it goes through this big arched thing that we call the aorta, with the little smokestacks here, which go to your carotid arteries and subclavian arteries. So what are these squiggles? Well, we need electricity to make these muscles contract, okay? The muscles of the heart. So we can actually measure the voltage. So when we see the right atrium contract and the left atrium contract, because they both contract about the same time, we see a little bit of voltage increase. Remember, because in order to give electricity, we got to increase the voltage there. So the voltage increases in the right atrium and the left atrium. Okay, and when we see that, this direction when going up is positive, and then this direction going down is negative voltage. So negative voltage, would be moving away from an area, and positive would be moving towards. So when we're measuring, depends on where we're looking, but we can see positive or negative direction. So what happens is, in the right atrium, there's this thing called the SA node. Now the SA node lets out basically a little burst of electricity every 60 to 100 times per minute. That is the reason why your average heart rate is 60 to 100 beats a minute, because that SA node fires on average that rate. So it sends out a little bit of electricity, and it causes the right atrium, that muscle in that area, to contract, and the left atrium. And when we see that happen, when we see that electricity go out, we see a positive deflection, and we see what's called a P wave. So this P wave means your right atrium and your left atrium are contracting. Now you'll notice there's this little pause here. That's because we talked about the SA node, but when the SA node fires, it contracts the atrium, and then it goes to what's called the AV node. That stands for the atrial ventricular node. So it's in between the atrium and the ventricles. That's why we call it atrial ventricular. And what this does is the AV node actually slows that electricity down. It makes it like, it's kind of like a gate, and then it kind of holds it back a little bit before it, lets it rush out. And the reason why that's good is when we pump blood into the ventricles, we don't want the ventricles pumping the same time the atrium are pumping. Because if you think about it, if you're trying to squeeze something into something while it's trying to be squeezed out, doesn't work too well. It's kind of two competing forces. So we want to pump the blood in, wait just a second so the blood has a chance to get in from the atrium to the ventricles, and then we squeeze the ventricles, and then boom, we can shoot it out. So this is the atrium contracting, and then there's a little pause because we went from the SA to the AV node, and the AV node slows that electricity down a little bit. But then as soon as it gets through the AV node, boom, it shoots through this area, which you can't exactly see because it's covered up by the outside of the pericardium, or I should say myocardium. And this is called the septum. So it divides, you have the one ventricle on this side and the other ventricle on this side, and the septum divides it in between. So you have all this electricity shooting through this septum through what's called the bundle of His, and then also the left and right bundle branches. So it shoots through those, and then what happens is then they go through here, and then they innervate and stimulate the ventricle muscles to squeeze and push all that blood out. So the atria are contracting on the P wave, and then the AV node slows it down a little bit. Typically it's a little longer than 0.12 seconds is what we want to see. And then boom, you see this huge spike, and that's the electricity traveling through that septum in this direction at a very high voltage to stimulate these ventricles to give a good, nice, hard squeeze. Pump that blood out. Then what happens is once we go up, well, then we go down. So then when we go down, we actually go negative. And this is because of, long story short, electrolytes are flowing across membranes and between cells, and so then what we have is we have to repolarize, and I'll just make it super simple here. We'll just call it repolarization. Won't go into too much detail, where it has to basically balance itself back out, and so that's what this T wave is for. So it's pretty much following the alphabet P, Q, R, S, T, and then we do have U waves. For our purposes, we won't need to know about that. They don't happen very often. But this is the normal anatomy, but this is like the normal electrical activity of the heart when it contracts, specifically the atrium and the ventricles, and then, when it's repolarizing. So, repolarizing is just getting back to balance as far as getting those electrolytes back to, where they were originally, so it can start the whole process over again. So, when it comes to issues, though, of if we have issues with these blood vessels, which is what we're going to talk about with this guy's EKG, then the most important thing we look at is the T wave. specifically the S and the T, because when those are off, that can be an indication that we're not getting blood and oxygen, specifically oxygen, but the blood carries the oxygen to these areas of the heart. So, how does this blood get to the heart? I am glad you asked. Well, we have what's called the aorta here. I already showed you that. And then on the aorta, there's these little holes so that whenever, once the left ventricle contracts and squeezes blood out, well then, it's done squeezing, then it has to, open back up again to let blood in from the left atrium. When that happens, blood actually flows back a little bit and flows down through these arteries called coronary arteries. These coronary arteries supply blood to the heart. Your blood, your heart, you think has a lot of blood in it, but it has arteries too because it needs to supply, blood to the outside of the heart, where most of the muscles are doing all the contracting. So we have essentially two spots where blood goes from this aorta to the heart. We have what's called the right coronary artery and the left coronary artery. And the one thing you will see here is this left coronary artery will actually split off and form what's called the circumflex branch, or what we call the circumflex coronary artery. And then my personal favorite, the LAD, or left anterior descending branch. So this is on the front of the heart. So we're basically looking at the front of somebody's chest right now when we're looking at this heart. So this is the left anterior. Anterior means front. So it's on the left side, but also mostly front. And the circumflex kind of goes around to the other side of the heart here. And then the right coronary artery, mostly focuses on the right side of the person's heart. And then goes all the way down-ish here. So you can see we kind of are covering the whole main areas of the heart, with these arteries. So if we get a blockage, say, in one of these arteries, well, guess what? Say we get a blockage right here, where my pointer is. That means no blood is going to flow through here. If that happens, we don't get any oxygen to these muscles. If we don't get oxygen to these muscles die. And that's a problem because then your heart's not going to start, your heart's going to stop pumping. And if your heart stops pumping, well, you're going to die. So that's why understanding EKGs, especially, if there's any changes in that T-wave area, is super important because it can tell a lot about what's going on in a person's heart. And specifically, where is a blockage happening? Is it happening in the right coronary artery? How far down is it happening? Is it happening in the LAD, left anterior descending, or is it happening in the circumflex artery? And we talked about all these leads, and they're basically looking at different areas of the heart. So, that being said, I know this looks like what is going on here, but you'll notice also we had all these things 1, 2, 3, AVR, AVL, AVF. It's like what are these? V1, V2, V3, V4, V5. These are all looking at different areas of the heart. So if we zoom in on this guy, lead 1 specifically, we put leads here and we put leads here. So with lead 1, we're measuring the electrical activity going from the right arm to the left arm. So lead 1 is measuring from this side of the heart to this side of the heart. When we do that, we're actually looking primarily right here on the heart. And you can actually see it. There's a really good diagram right about here on the heart. So leads 1 and AVL. So AVL stands for augmented vector. So basically, we're augmenting the vector, and then specifically left. So augmented vector left. AVR means augmented vector right, and AVF means augmented vector foot. So foot, is looking towards the bottom of the heart, left is looking on the left side of the heart, and right is looking on the right side of the heart. So when we look at these leads, we'll notice 1 and AVL are looking kind of at the start of the circumflex artery right in this area. And then we have lead 2. This is called an inferior lead. Why? Because we're measuring from the right arm to the left leg. And when we do that, we look at the bottom or inferior side of the heart. See? When we look at lead 2, it says inferior. Lead 3 is also inferior because that goes from this side to that side. And then AVF is also inferior because we're looking at the augmented vector foot. So we're looking at the bottom. So if I zoom in here, this shows you a nice area of where we're looking with all these leads. So inferior leads would be 2, 3, and AVF. We're looking at the bottom of the heart. We're looking at the bottom part of this right coronary artery. And then the septal, so the septum I told you is that dividing point between the two ventricles. That's primarily looked at by leads V1 and V2. This is V1 right here where my mouse is, that lead when we put the patch on, and V2 is right over here, looking at that septal area. And then as we keep going over with V3, V4, V5, and V6, we'll slowly work our way over. So our anterior leads, which means the front, so this is the LDA, left anterior descending, those are being focused on by V3 and V4 primarily. And then we get more lateral, which is more the circumflex artery, that's more V5 and V6. So this is just kind of showing you, like, why do we have all these leads? Why do we have 12 of them? Well, you know what? We want to look at all these coronary arteries. And the only way we can do that is if we actually put patches in a very specific spots all around this person's heart, so we can get a good, almost 360 view of what's going on with the electrical activity of the heart. So, why is this guy, what's wrong with him? I'm glad you asked. Well, whenever we have ischemia, and ischemia basically means lack of blood flow. If we have a lack of blood flow, that means we have a lack of oxygen. Whenever we get ischemia, we will see what's called an ST depression, but even more so than that, we'll see what's called an ST elevation. Now I told you that this thing, we had the PQRST, so what I'm highlighting here, that little bump going up, that's the T wave, right? Well, you notice this T wave here actually goes down. We call that ST depression. So it's, remember, P, Q, R, S, and then T. So this one's somewhat normal. But then you see this ST, and this S, and then this T part, that's depressed. And what I mean by depressed is it's below the average electrical activity area, or what we call the isoelectric line. It's below it. Notice that S and that T is below the normal area, versus if we look at like lead 2, that's pretty much above on average for the whole entire thing. So we learned about these coronary arteries, what we're looking at, and now we're going to talk about what STEMI criteria. And the one who got this this question right was actually Joseph Henderson, which makes total sense. He's a paramedic, so he probably knows. He's seen more STEMIs in my life than I have. But here's the criteria. For our guy was 32 years old, and he was a male. So in leads 2 and leads 3, we need to see a 2.5 millimeter greater than or equal to millimeter increase in V2 or V3. And in all the other leads, we need to see a 1 millimeter increase. Specifically in that ST area, that ST segment, we need to see an elevation. And STEMI, by the way, means ST elevation myocardial infarction. So myocardium is your myocytes is your heart cells, and myocardium, so specifically the muscle cells of the heart. And then infarction just basically means something died. So an ST elevation, usually if we have an ST elevation, that means we're having a myocardial infarction. That means cells in your heart are dying, and that's a problem. And so this is the criteria of like, okay, well, when is this actually typically happening? And this isn't cut in stone as far as, if people's hearts are dying, you're not going to see this all the time if they have an occlusion. Some people are slightly different, but in general, this is the criteria we go off of. So back to here. So when we're looking at this guy, so lead 2, Well, notice we have ST depression. So the S part of that wave, so we have our P, Q, R, S, and then the T. That's like this down-up little motion. We call that a biphasic T wave, ST depression. That's an issue. And so we see those in leads 2, 3, and AVF. Those all look pretty similar. Okay, so we have ST depression. That's a problem. Because if we look over here, 2, 3, and AVF, those are our inferior leads. So they're looking at the bottom of the heart. But where it's more of a concern is when we see ST elevation. So the opposite of the inferior would be more your top side in this, circumflex artery area. And so that would be more lateral. And guess what? Leads 1 and AVL are over there. And if you look at AVL, this is starting to look more like an ST elevation here. You'll notice that instead of that ST going down, it's actually going up. And that's an issue. And what's actually really bad too is that this T wave is what we call hyperacute, because the T wave is actually the same height as the R, and that's usually not a good sign. Like this one, you see this R spike up really good and down, and then, look at how proportionally this is less than half the height of that. And with this guy over here, he's about the same height. That's a problem. And you can see also in leads 1, we also have issues. This isn't technically STEMI here because we don't have, greater than 1 millimeter and change up. In fact, it goes down just slightly, but these T waves are about half, if not just slightly higher than half of the QRS, which is a problem. So these are our lateral top leads, lead 2 and AVL. We look at this over here. Leads, sorry, not 2, 1 in AVL. My bad. 1 in AVL is looking at the circumflex artery, but now we move on over to our chest leads, V1, V2, V3, V4, and you'll notice, boom, right here, we have a huge bump up. What we call this is a tombstone, and it means the person's going to die if nothing happens. There's some times where this can happen in people, and it's not really that bad. It's called a left bundle branch block criteria that we exclude it, if they have this. But that's another story for another day. But we have this huge big bump, and you'll see even another one that I think we call these De Winter's T wave morphology. It kind of look like sailboats or shark fins, is what some people say. This is an issue, and you'll notice these are huge. In V1, is pretty big, but V2 gets even bigger. So V2 is bigger, along with V3. Where do you suppose we're having issues with this guy in his heart and his coronary arteries? So if we're looking V2, that's septal, and V3, we're probably having an issue with this artery right here. There's probably something blocking this left anterior descending artery. So if we keep going, we look at V4. This is clear-cut STEMI. This is a clear-cut ST elevation. Look at that. This is, supposed to be the QRS here, and then boom. So that's the R. And then look, that's probably over 2 mils. And boom, it has huge takeoff there. We call this a hyperacute T wave. And it goes after the R, and it just boom takes off, and it actually goes even higher than the R. Usually when you're looking at STEMI, specifically if it's more anterior lateral, V4 is going to be the best bet to look at as far as seeing that ST elevation. That's huge there. So if we look at V4 section, V4 would be our anterior. So yeah, this is right in our LDA. So it looks like the main problem we're having is with our LDA. Now if you look at V5 and V6, we're kind of having almost the same stuff with AVF and lead 2. So we're seeing depression here, which is not good, but it's not as bad as the STEMI. It still means like there's ischemia going on. But it's showing you that most of our problems are happening in these septal/anterior leads, because when we start to get V5 and V6, it's more the lateral area, which is part of your circumflex artery. So it seems like our circumflex is not having really much occlusion, if any. and it's mostly your LDA. So when we actually look at something really cool called an angiogram, this is the person's heart. You can kind of see the silhouette. I'll trace the outline of it. And then these are the coronary arteries. I'll go back to showing you the coronary arteries. So we have your right coronary artery and your left coronary artery. And we're seeing most of the issues was with this LAD. And being that it was so pronounced here, and then also AVR, we didn't talk much about that one, but that was showing some issues. AVR looks mostly at this right side, mostly looks over here. We have some issues there too. But, where was I going? Yeah, anyway, so most of our issues seem to be happening with this LAD, or LDA, left anterior descending. As we can see all the, these hyperacute T waves, ST elevations here in our anterior leads right in this section. So, going back to the coronary arteries, we'd probably expect a blockage somewhere around here. And what happens is, we're not getting any blood to this area of the heart. So that means, we're having dying tissue there. But it seems like the left circumflex artery is still going. So with this person, this is called an angiogram. And what they do is they stick basically what's called a catheter in your femoral artery is probably the most common spot they're going to do that. So that's right kind of, on your hip, closer to your groin area. They put a little hole in there and they stick this in your big arteries, your femoral artery, and then they push it up into your aorta. You'll notice this goes up and then around and then down. You know what that's following? That's following this aorta. They pushed it up and then they shoved it into this coronary artery here. And what they do is they inject this dye under what's called fluoroscopy. Fluoroscopy is basically just X-ray images, and then when you inject this dye, you can see it turns a dark color under X-ray. So over here is actually, this view looks a little different from what you see over here, and part of that has to do with how they angle the X-ray machine, the X-ray machine there. And so you'll notice here, this is actually the left circumflex artery, and this one's flowing, it seems, pretty fine. But over here, this is supposed to be your LDA. There is nothing flowing through that thing. So that's exactly why we are seeing our hyperacute T waves right in this area, because our left anterior descending artery is not getting any blood flow. So what they did is they came in here, and what happened is this guy had a plaque rupture, and it went over and occluded this artery. So what they had to do is they had to kind of like clean it out there, and then they placed what's called a stent, which basically is like it's like a wire mesh, and then they expand it so it basically holds the artery walls out to allow blood to go in and out. Mostly in, because it's an artery, so shouldn't be going out. Shouldn't be going out the veins. So yeah, they stented this guy, they cleaned it out and stented it, and then I don't have the after photo, but you would see basically this whole area over here would then look like this right after they did that. And this guy actually recovered. So that's it. That's what happened. Joseph Henderson was right. So this guy had what was called a widowmaker. He had an occlusion in this area, very proximal LDA occlusion in this LAD. And that's called the widowmaker because it supplies the left ventricle of the heart. And that's very important because that pumps out blood out of your heart. And if that dies, well, you're not going to pump blood. So that's that. Thanks for watching.